Go. My apologies. I don't want you to miss out on any exciting word of this exciting lecture, right? What's that? Oh, yes. Well, of course. I hope Sergeant Lewis is feeling better soon. Does he have the flu? What? Whoa, okay, all right. Oh, okay. Yeah. Well, the flu's going around, you know. The H1N1 is affecting a lot of kids, and I think parents are starting to get it now too. There's a few folks from the lab who are out sick today as well. All right. So, did you all get your seasonal flu vaccine though? Really? Huh. Well, then maybe you will be blessed to have two shot opportunities by that time, because by that time we may have the H1N1 vaccine available too. Now, you all know that the seasonal flu vaccine isn't going to protect you against the H1N1. You have to have both, okay? But we don't have it yet, so it's on its way. Okay, the cell cycle. Remember this, like I said, back in Module 4. Again, you really have to understand how the cell is replicating. It's divided into phases named M, G1, S, and S2. M is the period of actual cell division. When one cell becomes two, it's called the mitotic phase, but there's some preparation that occurs before that. G1 is a period of normal cell metabolism, but without DNA synthesis. Cells which actually stay in this phase for a long period are actually referred to as G0, kind of inactive. S is a period where the DNA doubles. Okay, so the cells getting ready to divide, and only the DNA has doubled. G2 is this tetraploid stage which precedes actual cell division. Now, normal cells are renewing and expanding tissue, and cancer cells actually have similar cell cycle times, although so they go through the same phases, whether it's a benign or a tumor cell, but they go through it in different times. You know, some of the malignant cells may be showing a lot more mitoses and are going to show a lot more division, but generally they still follow the same phases. They may spend a different amount of time in each phase. But the problem with tumors, not only do you get cells that are actively dividing, what happens is that one of the things that sets out tumor cells apart from normal cells is that the cells don't have, normal cells are going to have mechanisms in place like brakes that are going to stop this uncontrolled cell growth and division, whereas tumor cells tend to have mutations in them where they don't get the necessary suppression, this normal braking mechanism. So you have absence of growth, or absence of suppression, and therefore the cells will continuously grow out of control, potentially. All right, so it's the absence of the suppression that kind of sets them apart from normal cells. It's a combination, okay, but that's one big piece of it. All right, again, the cell cycle, G1 or G0, depending on how long it's in that phase. S for synthetic phase, which actually represents late interphase and early prophase of mitosis. G2, prophase. M, mitotic phase, which is where you actually get the division, which includes metaphase, anaphase, telophase, and then the actual mitosis, cell division. And again, here's a non-dividing cell. There's each of the non and the dividing cell have the same M phase, but the non-dividing cell spends more time in interphase, or the G0 phase, than the other phases, whereas the dividing cell is going to be, preparing for cell division. And again, the DNA synthesis in a cell cycle, the length of time really depends upon the cell type, how actively dividing it is, but in general, cells only spend a very small portion in mitosis. This is an average cell that's dividing. It spends less than an hour in mitosis, whereas it spends much more time during the G1 and the synthetic period, and then a smaller amount of time in the G2 period. Now, this is true for normal cells that are replicating. Now, again, it's important to understand this cell cycle because it's really going to give us some insight into how therapy is used to affect the cell growth and the cell cycle. There are three distinct fractions of cells within a given tumor mass, okay? And there's the dividing cancer cells, which are typically sensitive. Those that are actively dividing are the most sensitive to chemotherapy or radiotherapy. There are some cells that are temporarily non-dividing. They're less sensitive, particularly to the cell cycle phase-specific chemotherapy agents that we're going to talk about later. And then you have some permanently non-dividing cancer cells that are refractory to chemo, radiation, any other type of non-surgical treatment. Now, I think it's, tumors that actually have more dividing cancer cells are going to be the most responsive to chemotherapy or radiotherapy. And of course, the larger the tumor size, the greater the fraction of cells will be in that third compartment. That is the one that's non-dividing. And they're going to be less sensitive to drugs or radiation therapy. Tumors are usually in the later stages of their biologic growth when discovered. And it becomes, there's been so many studies that have been done by oncologists who have, and pharmaco-oncologists to look at exactly how to treat a given tumor and how to affect its division. Now, there are different types of treatment modality. Single modality treatment, which means a patient for a given tumor is going to get either just surgery alone or radiation therapy alone or chemotherapy alone, is appropriate for some tumors, but not all. Most tumors actually require a multi-modality approach, which includes a combination of surgery, radiation, and chemotherapy, along with the use of combinations of drugs and radiation therapy in some cases on very well-defined treatment schedules. The oncologists, they don't just kind of look at one person and say, well, let's try a little bit of this and let's try a little bit of that. They actually have the treatment protocols defined ahead of time based on the type of tumor, how far it's progressed. So what's the most important thing that's going to determine what type of treatment a patient gets? The stage of the tumor. That's right. It's how far it has progressed. So stage is actually one of the most important factors in trying to determine the type of therapy for certain types of tumors. For instance, let's take, since this is now, we're in October now, it's now Breast Cancer Awareness Month. Okay, last month was Ovarian Cancer Awareness. Now we're into Breast Cancer Awareness Month. And don't worry, you guys, there's a month for prostate cancer too. I'm almost certain of that. So I don't want you to feel like you're left out here, okay? But the breast cancer, it depends on the stage as to what a patient gets. If a patient has a breast mass that's cancerous, that's confined to the breast, it hasn't spread to the axillary nodes, it hasn't spread to any other distant sites, those patients are treated surgically only for the most part. Now, sometimes they get radiation therapy localized to the scar area and sometimes to the nose to prevent recurrence of the tumor, especially if they did like a small lumpectomy and the margins were close. And so they'll go in and they'll actually give the patient a little bit of radiation therapy to prevent recurrence. But if the breast cancer has metastasized to an axillary node, which is the first place it goes when it metastasizes, that patient is now a stage 2 and will get recommended for chemotherapy in addition to radiation therapy to the axillary nodes. So really, staging makes a big difference for these patients. And if the breast cancer has already spread to distant sites like the lung, the liver, other types of treatment need to be considered. Different types of chemotherapy will be offered. Breast cancer patients may be offered anti-hormonal therapies, anti-estrogens, which we're going to talk about later, to help prevent recurrences. These are all very important. So really, it all depends upon the type of tumor and the stage as to what type of treatment they're going to get. And most often, it's going to be a combination of treatments. And this is true for female genital tract cancers as well. All right, the therapeutic potential of drugs, which is defined in the terms of fractional killing effects, is enhanced and the evolution of resistant cell lines is suppressed. That's the goal. These events are easily understood again in the context of cell cycle and growth compartments of the tumors. Now, even though chemotherapy and radiation therapy shows selectivity for cancer cells over normal cells, always remember they are also toxic to the normal tissue components. So patients getting these agents their normal cells are also at risk. And again, the goal for the oncologists, whether it's the medical oncologist or the radiation oncologist, is to make sure that they limit the treatment to what they need for that tumor and to try to minimize as much as possible the effects on the normal cells, which are going to happen. And again, the damage, and we're going to talk a little bit about what types of effects we're going to see from both the radiation and chemotherapy. And again, these changes can occur in both the tumor cells and the normal cells. And in fact, what we're going to look at first, once we get beyond some of the basics of radiation here, is to look at the effects on the benign cells before and then we'll study the malignant cells. All right, we're going to first talk about radiation. Radiation, you've probably all have had some CBRNE exposure. Actually, you have to have if you're in the Army, right? Okay. And maybe others of you have had some additional training on those processes as well. So just a very, very brief overview of radiation before we look at its effects. Now, in the medical community, radiation is often referred to, as for therapy is referred to, abbreviated as XRT, XR for X-ray, and then T for treatment. So sometimes you'll hear it abbreviated XRT. Now, there's different types of radiation, X-rays, gamma, alpha, beta, proton, neutron. We're actually going to focus primarily on X-ray radiation effects. What is the cause of damage? Well, the mechanism of radiation damage is its damages to DNA, which results in chromosomal aberrations or mutations. The cells in the S, G2, or the M phases are more susceptible to the effects of radiation. Now, the damage to cytoskeletal elements in the cytoplasm can lead to injury to the membranes, cell lysis, and eventually cell death. Again, this is showing you radiation causing breaks in the strands of the DNA. That's damaged DNA, and eventually the effects are going to be seen within the cell itself. Some basics of radiation that you need to be familiar with. The principle of radiation effect is the transfer of energy results in ionization. The definition of RAD is something to be familiar with. RAD stands for radiation absorbed dose, which is equivalent to 100 ergs per gram. It's a type of dose that's used to measure it's the dose of radiation that's applied. It's the standard radiation dose unit. Some people refer to it as REM, which stands for Röntgen equivalent to man, which is equivalent to 1 rad of X-ray or gamma ray. Now again, you must have a history of XRT to make this, actually this kind of doesn't really fall into the basics here, but I just want to highlight again because I've already told you about XRT. A patient has to have the history of radiation therapy if you're going to call radiation effect. Makes sense, doesn't it? Because they can resemble some other atypias. So those are the basics. What are some of the initial radiation effects? Again, it results from the ionization of the molecules. You get depolymerization of the DNA with loss of histones. Now, the damage can be either reversible or irreversible. Some of the cellular changes include restriction or reduction of mitosis, chromosome aberrations, membrane damage with altered permeability, and cytoplasmic structural damage. Quite toxic to the cells, actually can be, okay, not always. Now there's different ways that radiation therapy is delivered. One of the more common is external beam, where the patient actually has, surrounded by this radiation machine that delivers a beam to a specific site. Has anyone ever seen a patient who's been marked for radiation therapy? They go in and they actually, before a patient starts external beam radiation, they're going to limit the radiation beam to a specific area, and it has to be very carefully placed. And they do it all by computers now, which is good, okay? And they mark the patient with some permanent markers so that every time, and they have to go in for the radiation therapy over a period of days, sometimes every day for a period of several weeks. And they go in and they get a beam to a certain area, and they want to make sure they get the same area every single time, so they mark them to be able to make that process easier. And again, external beam radiation is used for things like when patient gets metastatic lesion to one of the bones. It can cause a lot of pain and discomfort and make the patient at risk for fractures, and you don't want to have fractures occurring, pathologic fractures. So one way to treat it is to treat it by radiation therapy to that particular site. And so again, that's an example of an external beam. I've got a picture coming up here just a moment. Other ways that radiation can be delivered is interstitial, where actually seeds are inserted surgically. That's actually done for patients with prostate cancer, where they actually go in and they put radiation beams right into the prostate gland through the urethra for treatment of prostate cancer. So instead of having a prostatectomy, this is another viable form of therapy. And the other is also injecting radioactive fluids into the bloodstream is also a form. The other one is intercavitary. Now we see that more often in the female genital tract, where they actually place a radiation source into the cavity, like the vagina, to help treat a cervical cancer. There's actually a form of therapy, it's called brachytherapy, for cervical cancer. It's just a radiation device is put right into the vagina. Some bladder cancers are treated like this too. Again, these radiation devices don't stay in there for a long time. They may stay there for a period of weeks, and then they go in and remove them. I'm not a radiation oncologist, and the radiation oncologist is a person who actually specializes in delivering, evaluating, and determining the modes of radiation therapy for given cancers in oncology patients. You'll get to meet some of the radiation oncologists when you go over and start your clinical rotations at BAMC, and you get to participate in the GYN oncology tumor boards, and you'll get to hear what they're talking about as far as different types of radiation therapy and different doses. Now, the extent of injury caused by radiation, both on the tumor cells and the normal cells, is going to depend upon the type of radiation. Is it external or internal? The internal being either the implants or the brachytherapy methods. The other key parts to radiation includes the amount of dose that's given, because there's different doses that are given for different tumors and different stages and different sites for different periods of time. And a patient is only allowed a maximum dose of radiation. Once you've gotten to that maximum dose, you can't get any more, or else you put yourself that patient gets put at significant risk for other bad things happening and other bad effects from the radiation, including other tumors. So the patient can only get certain doses. And again, I've already mentioned it depends on the type, the dose, the duration of exposure, how sensitive the cells are to the radiation makes a huge difference. And of course, the individual patient, how well they're able to tolerate the radiation exposure. The radiation beam itself doesn't feel like anything, obviously, but I mean, think about when you get a chest x-ray. That's a form of radiation, when you get a chest x-ray. Obviously, we try to minimize, the amount. It's a very minimal amount of radiation exposure, but it is a form. You don't really feel anything from that. And those who are and young and still would like to have children, usually we protect the the genital organs during those kind of exposures. But with the kind of lost my train of thought there for a second. I'll come back to it. But the individual patient, it really depends on how well and what good a condition they are to be able to tolerate the radiation. Oh, I know, it was the effects of the radiation. Now, what happens after the beam is received is that the beam will start to cause some damage. And there may be some initial effects within a few hours, but there may be some long-term effects too that kind of persist for some time. All right, so tissue sensitivity, which is one of the factors important in understanding radiation effect. First, we're going to learn which tissues are more sensitive than others. Now again, it depends on the phase they're in. The tissues that have cells that are in the M phase, the G2, or the S phase are actually less sensitive. The most sensitive cells are those that are showing the greatest reproductive activity, the longest period of mitosis, and the least morphologic and functional differentiation. So M, G2 are most sensitive, S is less sensitive. And that is important to know. Now again, tissues vary on their degree of radiosensitivity, and the degree of radiosensitivity in the tissue is going to depend upon the minimum amount of radiation dose that causes damage. Okay, so in other words, tissues that will be sensitive to 2,500 rads or less. In other words, they're very sensitive to radiation. They don't need a very high dose of radiation to cause damage. So 2,500 rads of radiation can cause severe damage, and that includes some normal tissues like lymphocytes, bone marrow, other bone marrow elements, germ cells from like the ovary or the testes, GI epithelium, respiratory epithelium, and renal epithelium. These tissues are radiosensitive because they don't require a lot of dose of radiation to cause damage. The tissues listed here are considered radioresponsive. They're kind of in between those that are radiosensitive and those that are totally resistant or nearly resistant. So radioresponsive is kind of intermediate. And here it requires 2,500 to up to 5,000 rads. And I have to tell you that right now 5,000 rads is kind of the max for some patients for radiation, a cumulative radiation dose. But tissues such as skin, endothelium that line vessels, salivary glands, other exocrine glands, collagen and elastic tissues, again, they're in this radioresponsive category. Whereas those that are resistant really require higher doses of radiation, up to and more than 5,000 rads are required to cause severe damage. It includes tissues such as neurons, muscle, bone, a lot of our mesenchymal, tough tissues. They don't divide a lot, okay? It's the mucosal surfaces that do divide a lot, so that's where you're going to see most of the radiation sensitivity. But liver and endocrine glands also are in this category. So there's actually now those were focusing on the normal cells, but we also have neoplasms that kind of fit into these categories as well. And again, it kind of follows the rules of the cells that we saw for normal that are either radiosensitive or radioresistant. So the tumors that tend to be the most sensitive include ones that are highly dividing, rapidly dividing, such as lymphomas, germinomas, squamous carcinoma of the cervix, oropharynx, or skin, and small cell carcinoma of various sites, most commonly the lung. Radioresistant neoplasms include those tumors such as that arise from mesenchymal tissues, such as the neural origin, the muscle origin tumors, like leiomyosarcoma, rhabdomyosarcoma, are muscle tumors, malignant muscle tumors. Osteosarcoma, chondrosarcoma are bone and cartilage malignant tumors. And then squamous cell carcinoma of the lung also falls in this category, as well as some adenos seen in the pancreas and the colon. And again, you just need to be familiar with those. You may be asked questions about what's most radio sensitive and what's most radio resistant, both amongst the normal and the tumor cells. What's the objective of radiation therapy? Again, probably the most important thing that radiation provides is palliation. Cures are rarely possible in patients who are at the point where they actually need radiation. It's in most cases, there are some tumors like prostate carcinoma, some of them are treated by radiation, especially the implants that go right into the prostate gland have been shown to be just as effective, if not better in some cases, than surgery in the long run. But probably the most important reason that radiation is given is for palliation, is to inhibit or retard the growth of tumor. It helps to prolong life, increase comfort, and it's often used if the tumor is inoperable. And the prognosis is really going to depend upon the tissue sensitivity. I had some personal experience with this a couple of years ago, not personally me, but in my family, where my father-in-law was admitted for, he had metastatic kidney cancer. He actually was admitted here at BAMC a couple of years ago, and he was having some symptoms of weakness in his lower extremities, which is a new thing. He just woke up one morning and he couldn't walk, basically. He had total weakness and paresis of his lower extremities. Brought him in, and it turns out that he actually had found to have metastatic cancer to his vertebral column, and it was compressing on his spinal cord. And that turned out to be an emergent condition. That's when you actually have spinal cord compression is an emergency. So they actually had to start treating him with radiation therapy right away, and to help shrink that tumor down immediately, which and it did. It worked. It got rid of the tumor compression, and it did help for the time being at that time. But it really brought to light how important radiation can be in certain situations, and that was actually one of the emergent uses of radiation, is when they come in with spinal cord compression from metastatic tumor. All right, so radiation therapy can cause normal tissue necrosis and scarring in the long run. It can cause inflammation of the mucosal surfaces, to include the intestine, the respiratory tract, which can lead to ulcers and bleeding. Mutation induced in other cells may cause new malignancies. In other words, a patient getting treated with radiation therapy for a lymphoma, for instance, which may be the treatment for certain types of lymphomas, and if it's cured, they may be at risk 20 years later for another type of tumor, a sarcoma of the bone that might have been exposed in that same radiation field, for instance. So that's why you have to try to limit the doses to not give any more than the maximum allowed based on the information that they have from the literature and all the other studies. Okay, some pictures. This is an example of how external beam radiation is applied by a linear accelerator. We have a few of these actually at BAMC. This is a typical equipment seen in a radiation oncologist's office. The patient will be down here on the table, and they're going to direct the beam exactly to where it needs to go. Again, you want to try to limit the effects on the other normal tissues as much as possible. But as you know, if a patient is getting, say for instance, radiation therapy to the hip or to the pelvic area for tumor in the bone there, for a met to the bone there, there's always going to be some bowel in the way, because you can't, it's hard to adjust the radiation beam so it's not going to totally miss the bowel that's in the abdomen next door, okay? So there's always going to be some kind of side effects from that, and probably most often those patients are going to see some problems from the GI inflammation due to the associated radiation. But the good news is that gets better over time, and they do give them some medication that's going to help make the symptoms, try to alleviate some of the symptoms. All right, here's an example of a patient getting radiation therapy or XRT for cervical cancer, and what they're going, this is actually a stage 2A cervical cancer, and it's just showing you the extent of the cancer right now in the cervix, as you see here through the speculum. And again, what they're going to do here is try to, they're going to insert either a device within the vagina, or sometimes they actually do have external beam radiation they can also apply. Here's an example of a patient being set up for external beam radiation. They're going to provide a total of 5,040 rads. Sometimes it's abbreviated using the Curie units, as you see here, but this is equivalent to rads, the SZCY. And what they do is they break out this total dose over a period of days. Okay, this patient was given 28 doses over a period of 37 days, which is a standard protocol for cervical cancer. You can imagine how difficult this is for patients, who are being treated for cancer. They got to come in every day for several weeks to get this radiation therapy. Usually they give them a break over the weekends, though. I've found that, Brachytherapy, this is again where you can insert devices. This is an applicator device into the vagina that's also giving a standard radiation dose over a period of time. And so this is the device within the vagina. And believe it or not, these patients, when they're at a certain stage, they don't need to have surgery. They're going to treat it, actually the best form of therapy for cervical cancer when it's a stage 2 is actually radiation, not surgery. It's actually the best form of treatment. All right, any questions on general things regarding radiation therapy? Okay, well now we're going to look at some histologic effects just briefly, and then we'll get to the cellular effects. Histologic tissue effects of radiation therapy are many. Probably the things that most commonly occur involve the vessels. The vessels around the tumor cells get dilated. The endothelial swells get swollen. There might be clotting within the vessels, that's thrombosis. The connective tissue surrounding the tumor gets edematous. There's often inflammation, at first neutrophils, then later on chronic inflammatory cells, and then in the long run, there may be fibrosis and scarring, depending upon the dose and duration of the therapy. Radiation necrosis is something that occurs acutely, and after a period of healing, then obviously there's scarring. And this is just highlighting the fact that there's some changes occurring. This is radiation that's going from a brachytherapy device for cervical cancer, and its effects on the vagina. The adjacent vagina is going to feel the effects, obviously, because of the radiation that's there. And at some point, you can get some fibrosis and scarring. Acutely, the acute cellular changes from radiation occur within 6 months, but usually it's from 2 days through 6 to 8 weeks following the radiation therapy. And these are some of the acute changes to be aware of. Nuclear and cellular enlargement. The cells get very big, macrocytes, okay? Vacuoles in the cytoplasm. Chromatin condensation, abnormal mites, multinucleated cells, cells with bizarre shapes. NC ratio typically stays normal, but can be slightly increased, but not as increased as you see in a malignant cell. And of course, there may be an inflammatory exudate. Chronically, these effects are seen at least 6 months after radiation exposure and can persist for many, many years, 25 or more, actually. And again, a patient who's had prior radiation 25 years ago, you may still see some of these changes in the normal cells. Cellular and nuclear enlargement, usually with a normal NC ratio, though. You can have bizarre cellular shapes, but the chromatin remains bland, okay? Bland chromatin, maybe some atrophy in the background on a pap test. Now, keep in mind the malignant cells undergo the same changes as benign cells do. And sometimes distinguishing benign from malignant radiation change can be quite difficult. But let's see if we're going to look at some examples. All right, first of all, radiation changes background tissue often shows reactive changes. These are some endocervical cells. They show what looks like repair, okay? You've got some nuclear enlargement, you've got nucleoli. Basically, it looks like there's reparative changes taking place in the background epithelial cells. That's very common. But notice how the cells are still regularly arranged. They still have benign architecture overall, but the nuclei are definitely showing some enlargement and other reactive changes. Now, the cellular effects that are seen during radiation therapy are all going to depend upon, like we talked about before, the total dose of radiation, the duration, the time since the last treatment, the source of radiation, and of course the individual patient response, an individual tumor cell response. And why is it important that we recognize these changes of radiation therapy? Well, first of all, it helps us to assess for recurrence of the cancer, assess the response to therapy. You know, after 2,000 rads, if greater than 70% of the benign squamous cells have radiation change, that's generally associated, some studies have shown that to be associated with a good response. But if you're not seeing the radiation effect, that may indicate a poor response to radiation. Maybe then we need to try something else. In other words, you know, you want the cells to be showing changes. The most change from radiation is going to be seen about 2 weeks, in general, 2 weeks post-radiation therapy. And of course, you always want to watch for evidence of disease that can result because of the radiation exposure. You know, obviously you want to treat the tumor, but because of the effect on the other normal cells, there's always a chance for other diseases to occur. All right, let's look at some examples. This is now what we're going to look at first is some cellular changes in benign cells due to radiation. Now, some of these are going to be mostly what I'm going to show you right here is some acute changes, but you may see some of these changes in the chronic period. Remember, chronic radiation effect is seen 6 months afterwards, and it can persist for years. The acute changes is often necrosis and acute inflammation, and we're not going to see a lot of pap smears in patients who are getting acute radiation. I would hope not, actually, because they would look kind of scary, okay? And in fact, you don't want to see a pap smear for a long time after they've had the radiation therapy, to be honest. First of all, but what are some changes that you can see? Now, in this particular thing, this image, we're actually seeing fairly large cells. This is a huge cell. Like, these are neutrophils for size reference. This is a gigantic cell. So macrocytes are typical. Vacuolization is one of the first changes seen, and vacuoles can occur in the cytoplasm or the nucleus, either one. But one of the first changes is within the cytoplasm, and they can persist for many years. You can see it in metaplastics. You can see it and I think most often we tend to see them in metaplastic in the glandular cells, but you can see them in the more mature squamous cells as well. We're kind of rare in the superficials. Now, inflammatory cells are sometimes seen inside those vacuoles, you know, like engulfed neutrophils, just like you might see in what type of cancer? Endometrial cancer. But again, these are benign. We're looking at benign squamous cells right now, can have vacuoles with inflammatory cells within them. So again, you have to pay attention to what company that they're keeping. Now, the dose averaged here is about 1,000 rads, where you can start to see about 25% of the normal background benign squamous cells with vacuoles. Here's some examples. These look more like metaplastic and glandular cells, but again, we've got vacuoles in the cytoplasm containing neutrophils. And you've got some other reactive changes, some other empty vacuoles. There's a lot of reparative changes going on here, a lot of reactive change. Very nonspecific. This could happen in a number of reactive processes. So radiation itself causes fairly pronounced reactive changes. Cell size often increases. These cells can get quite large, 2 to 4 times increase, sometimes more, can be seen at low doses, but is most prominent at 3,000 rads. Cytoplasm increases first after about 1,500 to 3,000 rads. Nucleus starts to increase also, but classically this is a key feature with radiation effect. Even though you're going to have these large cells, the NC ratio remains relatively normal. Now, the nucleus can have some atypia, but the NC ratio is still going to be normal. In general, the nucleus and the cytoplasm increase in size together in this situation. Okay, so here's the macrocytes with very bland nuclei. So large, again, if I saw lots of cells like this on a pap test, I'd have to wonder in the back of my mind if their patient did not have a history of radiation therapy. But I would want to know that history and have them confirm that for me before I actually called it. Here's another example of very large, several macrocytes with very bland nuclei, bland chromatin, nothing else really exciting going on with those nuclei. There are some neutrophils in the background, but quite large cells. Oftentimes the nucleus, it depends on, it depends. I think the cells that are undergoing the initial early acute radiation effect may show some nuclear atypia, where those more in the chronic stage are going to show more bland nuclei. And this might be more indicative of a chronic change. Here's some macrocytes with some nuclear changes. Again, what kind of things would you think about in the differential here? Multinucleated cells? Isn't there some molding there? Right over here, what's that? Doesn't that look like molding? So what do you think? Herpes. How are we going to tell this apart from herpes? Well, I don't know. This chromatin looks kind of ground glass to me. There's no internuclear inclusions. That's right. These cells also tend to be huge. I mean, just the biggest cells that you're ever going to see on a pap test. They tend to be quite large. Lots of cytoplasm. I think even though there's a hint of molding here, the other nuclei don't really show that. They're kind of separate. So it's not the classic molding. It's not the classic chromatin margination where you get the chromatin kind of out to the periphery. But certainly it can, you have to wonder sometimes. Okay, reparative changes, again, multinucleated cells, but still have abundant cytoplasm. So they still have a fairly normal NC ratio. Chromatin looks kind of smudgy, but fairly uniform, occasional nucleolus, and the membranes are relatively smooth. Again, this is another feature of radiation effect. Now, the radiation can affect the adjacent stromal cells, to include the fibroblasts of the connective tissue and the endothelial cells of the vessels. And the endothelial cells tend to get quite plump. Now, you haven't seen too many endothelial cells on pap tests probably, but they tend to be more oval shape, elongated. And that's what we're seeing here, is some of these elongated nuclei represent, and as do fibroblasts, by the way. They can look relatively similar, but they can get quite enlarged, quite plump, quite prominent. When you start to see lots of endothelial cells, if you were to see endothelial cells on a pap test, which by itself is kind of unusual, is a clue that there may be some vascular proliferation going on there, either due to inflammation or something like radiation. Now, cytoplasm also can show some bizarre cell shapes, including ballooning, elongated forms, tadpole forms, amoeboid forms. Nucleus may be normal or atypical, oftentimes depending on when the radiation therapy was received. This is quite bizarre cell. I know you're looking at this thinking, well, I've seen tadpole cells like this in squamous cell carcinoma, right? But notice the nucleus here. It doesn't look as atypical as you would see in a malignant squamous cell. All right? There is some atypia, no doubt. There's a little bit of irregularity here, but not as much as you would see in an outright malignancy. And remember, in a malignancy, usually the NC ratio is much higher. We're not really seeing that here, but we're also seeing these are huge cells, just gigantic. Look at the neutrophils in the background. You've got the vacuoles in the cytoplasm. Again, this is actually just a result in a benign cell, not a malignant cell, of radiation. It can cause these kind of changes. And now you can see how this can sometimes pose some challenges on cytology. And this is true throughout the body, not just in the female genital tract. All right, what else, what other things can happen to the cytoplasm? The staining can get polychromatic, variable, so you might see more than one color, just like you see in other inflammatory changes. You may get hair-like or thread-like fibrils in the cytoplasm. I think we actually saw a hint of that on the previous one. You can see a little, almost like a Herxheimer type spiral, which is due to abnormal keratin filaments, but this could be due to any number of cytoplasmic filaments. And they can occur in a perinuclear arrangement as well. Here's an example where you've got some polychromasia or bichromasia. Again, that's typical for inflammatory changes in general. You've got neutrophils, you've got enlarged nuclei with nucleoli, all kind of indicating some reactive type change. But in this setting, with the patient's history of XRT, that certainly supports that. The nucleus can show changes too. Its size can also increase. Even though the NC ratio typically remains normal, it still tends to increase in size, especially during the acute stages of radiation effect. You may see some slight membrane irregularities. They can be multinucleated. There can be nucleoli. There can be vacuoles in the nucleus. And there can be paranuclear halos. Again, these are all very nonspecific findings, to be honest. It can be hyper or hypochromatic, depending on how, the stage of the therapy, how far away from the therapy, how degenerated the cell is, because, remember, degenerated cells, the nucleus always looks hyperchromatic. Chromatin can become totally smudged. There can be irregular shapes, and then eventually when the cell dies, you get pycnosis, karyopexis. You could have mitoses occasionally, just like you see in other repair. Again, this is a cell that's showing multinucleation, but the nuclei look bland otherwise, as we saw earlier. Another example here of multinucleation with nucleoli, and definitely some atypia to the nuclei. But again, notice the NC ratio is very low. There's lots of cytoplasm there. That's very helpful. You notice there's vacuoles in the cytoplasm as well. And you can see vacuoles in the nuclei too. Here's some more examples. Now here, there's all sorts of things happening to these nuclei. I guess those are vacuoles. It could be some chromatin clearing. But these cells are looking very atypical. I'd be very concerned if I saw this, and I would call it atypical, no doubt. But this is the degree of atypia that radiation therapy can cause. And I would have a hard time separating this out from something neoplastic, to be honest. So don't feel bad. It's really challenging. Here's some examples of perinuclear halos. It just looks like any typical inflammatory effect, doesn't it? You can see that in a number. What agent typically gives you the halos? Trick, exactly. I would be looking around for trick if I saw those halos, but again, you can see it in radiation effect as well. And the key probably to help you in that is the fact that these cells are quite large, and you don't see any trick in the background, obviously. So, but I still look for them. And of course, this is showing you the typical nuclear degeneration that can occur, pycnosis, karyopexis, total lysis of the nuclei. Now, there are some other things that occur in association with some of these changes. Hold on just a second. The presence of histiocytes correlates with a good host response pre-treatment. It's been found. And during treatment, neutrophils and histiocytes persist. Histiocytes are probably going to be seen early on because they're there to help gobble up all the cellular debris. And then, of course, 6 months post-treatment in a pap test, you should see predominantly an atrophic pattern. That's the key. As often it's atrophic in the chronic stage. Here's an example of atrophy. Blue blobs everywhere, in addition to some enlarged nuclei. All right, what about the malignant cells? Again, it's the same effects that we saw with everything I've been showing you so far is all benign cells showing radiation change, but the malignant cells can show radiation effect just as well, and they'll follow the same pattern here, except the NC ratio isn't going to be as an important thing to other than the fact that the NC ratio, as true with malignant cells, remains increased, okay? But all the other degenerative changes are going to be common. Again, extreme cellular enlargement, pleomorphism, nuclear degeneration, and fragmentation. But in general, the malignant features are maintained. Of course, unless the cell is completely degenerated and necrotic, you're not going to be able to tell what's going on. But if it's an intact, viable cell, generally the malignant features are maintained. Thus, there's going to be more nuclear atypia than you saw in the benign cells and higher NC ratio, etc. So in other words, the bad cells become even worse looking, right? They become worse because of the accompanying radiation. And again, this isn't something you're going to see very often because it's not very common that they're going to be getting cytology on a patient who's just received radiation, okay? So it's very uncommon, but you never know. And you have to be aware of it and understand. Now, here's an example of a malignant cell showing radiation change. You notice its NC ratio is very high, unlike the benign cells, and you've got a lot of degeneration going. You've got a lot of necrosis in the background. Radiation can cause necrosis, so you're going to see a lot of necrosis and inflammation in the background. And I think that's what's being highlighted here, except for this one isolated malignant cell. This one is a picture of a malignant cell with radiation change. It again shows very high NC ratio. It's got vacuoles in the nuclei. It's got other degenerative changes. It's a very large cell. We don't have a good size reference here, but take my word for it. It's supposed to be a very large cell. Okay, so, all right, which one is benign and which is malignant? So one is the radiation effect on benign cells and one is radiation effect on malignant cells. Which is which? The one on the right, does everyone agree? Yes, no. Now, tumor diathesis isn't going to help you with radiation. I heard you say, well, now you can get necrosis in benign cells too, because radiation causes in the acute stage necrosis. So tumor diathesis isn't going to help you in benign versus NC ratio is the most important, is one of the most key findings. So tumor diathesis isn't going to help you as much because they can both show it, both benign and malignant cells. Well, you know, but here you can see here again the NC ratio is key. High NC ratio, low NC ratio. Then also notice how the sheet of cells here is kind of in a streaming sheet where the nuclei aren't overlapped, and that's a benign feature. That's like repair. Okay, it is repair, basically. Repair with radiation effect. Okay, and then this group of cells here, not only do they have the NC ratio enlargement, it's a very disordered group of cells. There's nuclei that are overlapping each other. The chromatin, it looks more irregular than the benign cells, although there are nucleoli here in the benign cells. The chromatin here is quite irregularly dispersed. The nuclear membranes are more irregular, so there's definitely got the malignant features here, but the key here is that they have abundant cytoplasm and they're in a flat streaming sheet. Okay, we got one more of these. Okay. I mean, benign, which one is benign cells undergoing radiation effect and which one are malignant cells undergoing radiation effect? Benign on the left? Everyone agree? The thumbs up? Okay. I have to tell you, I find this very challenging. But the answer is the benign on the left, malignant on the right again. I think the only thing here is that there is such pronounced membrane irregularities here and slightly higher NC ratio. But I have to tell you, it's not by much. I would find this quite challenging and hope that I would never see anything like it and have to make that decision, right? All right. A couple other things before we take a break. The tumor response to radiation, it's important to know these dates. If you want to know something, you better know these dates, okay? Initially, tumor cells after radiation will be shed in large numbers, and there's certain dates to be aware of. It depends if you see viable, and I'm talking about viable tumor cells here, not necrotic dead cells, but viable tumor cells. Less than 3 months, it's insignificant. It just patient hasn't gotten, the cells haven't had a chance to completely respond to the radiation. It means there's still tumor there. It doesn't mean anything clinically. Okay, so less than 3 months, it's insignificant. 3 to 6 months is borderline. But if there's any tumor cells that are shown in a pap test 6 months after treatment for cervical cancer, up to 5 years, that means persistent tumor. Okay, persistent, not recurrent, but persistent tumor. And if you find tumor cells 5 years after radiation, that means recurrence of the tumor. Okay, everyone clear on that? Now, persistent tumor may show many malignant cells, many mitotic figures, generally resembles a pretreatment tumor, which may have radiation change. Recurrent tumor may also have many malignant cells, but usually the cells are smaller, less mature, and less differentiated. So in other words, they look higher grade, less mature. Can't even tell if they may not resemble the original tumor. All right. One thing that we are going to talk about, but I think we're going to take a break right now. This is one of the effects that can occur in the female genital tract after a patient has received radiation therapy for cervical cancer. One thing that a patient is at risk for is actually developing dysplasia due to the radiation therapy, and not recurrent dysplasia because of the underlying HPV milieu, okay? And this is actually totally new dysplasia, different than the cervical cancer that the patient was getting treatment of. And so you need to be aware of dysplasia, and it looks a little bit different than the regular dysplasias, and certainly will look different than the cancer that the patient was being treated for. So we're going to talk about this when you come back, and then we're going to talk just briefly, a brief overview of the radiation therapy that occurs at other sites throughout the body. And then we're going to talk some about the chemo and mechanical therapy effects at the very end. Any questions on radiation therapy so far? All right, very good. I will see you back here in 15 minutes, which is, what, 5 of? Okay. Let's see.
because he went out there to go talk to him. So he's like, he's going to jump because he's a jump master, and he was trying to see if he can get some jumps. And he said, it's like, he has to keep his. He has to do so many jumps to keep his pay, right? Well, what I explained to him is you can't keep your pay. You can do what's called a if you're not in an airborne unit. It's the one that you can get like a ain't gonna go back proficiency waiver where you can get your duty orders to jump, but you can't get pay. But what that does is it keeps him up to date on jumps. He doesn't have to do jump master refresher or bar or anything like that. And so when he goes to his airborne unit, you won't have to worry about a transition, but you're not going to get paid for it, and you get more jumps a lot. So if you're searching for your read, then you got hours. Yeah. I'm gonna ask him. Hey, you said there's a game tonight. You said there's a goes off. Let's do this right here. I gotta cover my hand. It's open. Next time you doze off, I'm gonna tell her to do this. I haven't dozed off yet. You dozed off the whole time. After I how do you think I've been dozing off? You still on the notes I'm doing? You're the first one. No, I'm gonna wait. I drink so much coffee. You doze off the thing. Look. Look all the notes. I've been writing notes. All right, know that, man. Please. The next time you do it, I'm gonna take a picture of it. Stop. I look like I'm dozing off, but I'm right. No, you said just like this. I said, look at Farrah, he's gone. You said, Side loves me. I've been drinking coffee. See, that's why I guess. But I gotta get that. This is coffee. She's sorry, I'm done, man. I don't remember it, man. Man, the next time you see Sergeant Farrah do this right here,
Yeah.
just say, do this right here for me, okay? Just say 2-5.
Oh.
He said he don't be dozing off. He doesn't remember because he knows it. Just right here, man. Only thing I do is just right here. You know it with me.
2-5. 2-5.
I'm taking notes over here.
So does that mean 25 on each hand?
No,
one-handed push-ups?
25 minutes. Then you get a break for 25 minutes.
Okay. Oh.
He's so hardcore right here.
So I just got an email. I say this is the advantage of having BlackBerry, government BlackBerry. There's an executive order that just came out. Imagine this, saying text messaging while driving is prohibited. Yeah, okay, yeah. There's an executive order that came out specifically addressing text messaging while driving. And so no federal employee shall engage in text messaging when driving a GOV or when driving a POV while on official government business or when using electronic equipment supplied by the government while driving. So, like I could be 1,000 miles away and this still applies to me. Okay. But I never do any text messaging. Right? Can't do any text messaging on here. You can read email. Is that the same thing? No, I'm just kidding. So be safe out there. There's a definite. Did you all have to take the safety training modules recently that were put out by Medcom? Does that sound familiar? Oh, gosh, you're so lucky. Okay. Maybe it just hasn't got to you yet, but I think it's going to be a requirement. There's a whole module on safe driving and cold weather safety. Just what we need here, right? Okay. It's all a requirement. I don't make the rules. Okay. Anyone have any questions so far? All right. We're just going to talk a little bit about post-radiation dysplasia. This is actually dysplasia that's occurring that involves the non-neoplastic cells that in the area of the radiation, so that the patient actually gets dysplasia for another reason other than HPV, to be honest. I mean, but I have to tell you, it can be very difficult to tell the difference between recurrent a recurrent lesion, because remember, even a patient with squamous cell carcinoma of the cervix is always at risk for dysplasia occurring elsewhere in the female genital tract, always, okay? And so to be able to, because of the HPV effect and the influence it can have throughout the female genital tract. So to tell the difference from the HPV-related dysplasia from the radiation-related dysplasia can be quite challenging, but there actually have been some differences noted. I think it's just important for you to understand that these patients are at risk for developing dysplasia after receiving radiation for whatever reason. It doesn't even have to be for cervical cancer. It can be if they're receiving radiation to the pelvis for whatever reason, are at risk for developing this. And there's been a study that was done, and this is data from that study that showed that 22% of patients who had had female genital tract radiation therapy developed post-radiation dysplasia, and most of them occur within 3 years. There's a percentage within the first year, and it can occur anywhere within months to years after the therapy, but it's usually at least within 6 months, or it's not sooner than that, I should say. The features are similar to classic dysplasia, except most often the cells tend to occur in crowded groups rather than isolated cells, so more crowded groups. Prominence of oval or irregular shapes to the groups, and more eosinophilic or indeterminate staining rather than cyanophilic. Cell borders are often indistinct, which goes along with a hyperchromatic crowded group. As I mentioned, the eosinophilic cytoplasm is common. The mean nuclear area and relative nuclear area as listed here. The NC ratios generally are high, as is true with dysplasias in general. The chromatin can be finely granular but hyperchromatic. No nucleoli, rare chromocenters, and the estrogen effect can be seen in background squamous cells. Now again, post-radiation dysplasia tends to be a little bit more aggressive than regular HPV-related dysplasia. It tends to persist more often and progress more often than does regular HPV-related dysplasia. And very few cases regress, at least in this one study, and they do have a tendency to persist. So in that sense, they have a worse behavior than straightforward HPV-related. So again, higher progression rates than classic dysplasia, and I'm referring to that as the HPV type dysplasia. Residual or recurrent cancer accompanying post-radiation dysplasia may occur in the pelvis or distant mets, and diagnosis of post-radiation dysplasia within 3 years after radiation therapy generally implies a poor prognosis. In other words, those patients tend to do worse overall. Here's some examples. This one was called a low-grade SZCY of post-radiation dysplasia. Again, it's more clumped. That's all I can say about it. But they have the nuclear atypia that goes along with an L-SZCY, but they still have plenty of cytoplasm. So a little bit lower NC ratio than an H-SZCY. And here's some H-SZCY. This one is showing the eosinophilia to the cytoplasm. This one not so much, but they both show more crowded groups rather than isolated cells. And I think that's it. That's all I wanted to say about post-radiation dysplasia. I can tell you it would be very hard to separate out from the other types, but it is something to be aware of, and it is something that these patients are patients who receive radiation therapy to the pelvis for whatever reason are at risk for. Okay, now we have been studying the changes primarily to the female genital tract so far, but we're going to just briefly go over some of the other sites because as we go along through this is our last lecture for this module. Can you believe it? But you're not going to have any more lectures again really until January when we start the respiratory module, Module 9. I know, it's hard to believe, isn't it? It's just amazing. Where has the time gone? But in each module after that, for the non-gens, every site can show radiation change if that site's being affected by if that patient's getting treatment to that area with radiation. And really a lot of the changes overlap each other. There may be some specific things that are unique for a given site, but really not. It's all basically the same thing. Large cells with normal NC ratio, nuclear atypia, vacuolization, homogeneous chromatin, it's very similar, and you'll see the same changes in other cells throughout the body that have been exposed to radiation. It's really very much the same. I'll see if I'll point out what's different, but otherwise it's going to be similar. And this is just reviewing everything that we've seen already in the female genital tract. Here's the chronic changes that can persist for many years. Background is usually cleaner. The dirty background is seen most often in the acute changes. You can start to get scarring, and then you'll get the connective tissue fibroblasts, sometimes some foreign body giant cell reaction. An atrophic pattern, especially in the female genital tract in the chronic state, is not uncommon. Nuclei may look atypical but not dysplastic, and the NC ratio remains normal. Now, in post-radiation dysplasia, as I mentioned, is dysplastic changes that occur in previously benign cells that may follow radiation treatment. NC ratio is usually increased. The presence may indicate a poor prognosis for this patient. In other words, that dysplasia will have more of a tendency to progress and persist. And the presence of malignant cells in a post-radiation smear is considered a poor response to therapy. Now, what about other sites? Again, it's similar findings. The oral mucosa will show exactly the same findings as you see from the female genital tract. It's the same type of epithelium. It shows very similar findings. The respiratory tract, again, we'll look at some examples as we go along with this. We do see this occasionally because patients come in after some lung cancers can only be treated by radiation therapy, and sometimes they'll come back for evaluation of recurrent nodules, and the question will come up, is this radiation effect, or is this residual tumor or recurrent tumor? It comes up. Again, the bronchial epithelium here, which is a type of glandular epithelium, will show nuclear and cytoplasmic enlargement during the acute stage, but again, the NC ratio is still going to be relatively normal. There are going to be other reactive changes like nucleoli. The presence of cilia here actually helps to confirm that it's benign, because remember, when you see cilia, that generally you don't generally, obviously the cells that have cilia are always benign. Malignant cells do not have cilia, okay? And chronically, you tend to get scarring and fibrosis, and again, the cytologic findings in this setting are very nonspecific. The epithelial cells which that line the bronchial airways are glandular and ciliated. They're ciliated respiratory epithelial cells. During chronic inflammation or chronic inflammatory changes, they can undergo squamous metaplasia, just like the cervix does. The glandular epithelium can undergo squamous metaplasia. So the squamous and columnar cells may show some atypia. And similar effects are seen after chemo. As we'll talk about momentarily, a lot of the changes that we saw in radiation, we also see in chemotherapy effect as well. Now the bladder, again, shows similar findings. Affected cells get large, macrocytes, and large nuclei with usually bland chromatin, reactive changes, including nucleoli. Again, changes are similar to those seen in other inflammatory conditions in the bladder. The breast, again, same thing. Breast is composed of glandular cells as well as stromal cells, and depending upon the type of cell sample, you're going to see some atypia associated with it. And again, the same things, larger cells, but normal NC ratio, oftentimes with some atypia. Same thing in the prostate. In a long state, prostate is very commonly treated by radiation therapy. In the end state, the prostate gland that's been treated by radiation therapy in the chronic state often becomes fibrotic and atrophic. You may see some squamous metaplasia because, again, it's lined by glandular type epithelium, which in the reactive healing stage can undergo squamous metaplasia. We don't find this very useful cytologically. Same thing with the thyroid. Thyroid can undergo radiation therapy. Again, cells that undergo degeneration and necrosis eventually undergo some healing and will show some reactive changes during that process. During the chronic state, again, fibrosis and atypia, and again, large cells with normal NC ratio. Some inflammatory infiltrate in the background, smaller follicles. Now, we'll see some more of this when we start doing the thyroid. So that's really all I want to say about the other sites. But again, it's kind of a common theme throughout each body site. It's the cells are going to show similar features that we've already been talking about, no matter what the cell, where the cell is from. All right, the next thing we're going to look at is chemotherapy. Now, again, this talk about chemotherapy can be like several days of lectures, okay? If that's all you're going to do is study chemotherapy, and obviously that's not our focus today. I think the important thing to understand here is that chemotherapy very much resembles radiation therapy in its effect. Now, there's certain types of chemotherapy that will cause certain effects in some areas, and we'll focus in on those changes just a little bit. But in general, the changes are similar, including macrocytes, vacuoles in the cytoplasm, vacuoles in the nuclei, but normal NC ratio. Sounds like a common theme today, doesn't it? Now, there are different classes of chemotherapy. These are the 6 major agents listed here and in your handout. There's alkylating agents, anti-metabolites, natural products like plant materials, anti-tumor antibiotics. There's some antibiotics that are actually anti-neoplastic agents. Endocrine hormonal therapy is used. One classic example is tamoxifen for breast cancer. And then there's immunologic stimulants that can also be used as anti-neoplastic agents like Cytoxan. Okay. Now, the alkylating agents are agents that interfere with mitosis by preventing separation of the DNA strands, so it doesn't allow adequate division, and the cells become inactive. Now, this cytotoxic effect occurs throughout the cell cycle, but primarily during the S phase. These are different types of alkylating agents. Some of these are the most common chemotherapy agents that are used for a number of tumors today. See, I mentioned Cytoxan earlier, but actually that's not an immunoagent. We'll get to that later. But these things are really hard to keep straight, and they're changing them all the time. I'm telling you, there's new chemotherapy agents that are being developed all the time, but these are some of the very basic ones. I know that Cytoxan, which is a nitrogen mustard, also known as cyclophosphamide, is commonly used for treatment in things like lung cancers, ovarian cancer. Patients get treated with Cytoxan. But busulfan, that should be a U there, busulfan, not bisulfan. Busulfan or Myloran is also used for treatments of certain types of leukemias. Thiotepa is an ethylenamine derivative, which is used in treatment of some bladder cancers. And then there are some others listed here. Now, the next category was the anti-metabolites, and they act primarily during the DNA synthetic phase by preventing further entry into the DNA phase. It resembles a normal metabolite, so it's actually like a mimicker, and therefore it's able to enter the normal metabolic system and interfere with the normal pathways. And these include both folic acid antagonists as well as purine and pyrimidine analogs. Here's some examples. Methotrexate, folic acid analog. 5-FU is a pyrimidine analog, and 6-MP is a purine analog. These are all some very standard chemotherapy agents. Methotrexate is used for treatment in a number of things. And in fact, methotrexate is not only used for treatment of cancers, certain types, it's also used in treatment of patients with ectopic pregnancies. Did you know that? It's a non-surgical treatment for ectopic pregnancies. Women are given when they're diagnosed with an ectopic, rather than take them to surgery, as long as it hasn't, ruptured and started bleeding, they give them a couple doses of if not, maybe just one dose of methotrexate, and it actually specifically will cause degeneration of the ectopic pregnancy, and so that it eventually, the woman actually just basically miscarries what was left in the fallopian tube. It kind of degenerates and resorbs, basically. And it's obviously that option works for a number of women that when the ectopic is found in an early stage of the pregnancy. Later on, that's not possible, but it's quite effective. And all right, other chemotherapies, these are natural products, maybe coming from plants. These are agents which produce metaphase or rest in cell division. They interfere with the spindle fiber formation that's necessary for cell division. And agents such as podophyllin, vinblastine, vincristine are such chemotherapies. Now, I've known that vincristine is used for some treatment of types of lung cancers. Now, there are some anti-tumor antibiotics to be aware of. All of these, wherever you see a mycin or icin, something like that at the end, icin or mycin, that generally implies an antibiotic, okay? And again, these obviously antibiotics are used also for treatment of infectious agents, but these are specifically used for treatment of tumors. Probably one of the two most common here, actually there's several, adriamycin, bleomycin, and mitomycin C. Mitomycin C can be used for treatment in various bladder cancers. Adriamycin is used for a number of adenocarcinomas, and bleomycin is actually used for treatment of certain germ cell tumors like seminoma. Okay. If you remember the story of Lance Armstrong, when he was first diagnosed with metastatic testicular cancer, he was offered this option of being treated with bleomycin, but he refused it, actually, and they actually put him on a different type of chemotherapy protocol. And the reason he did not want it is because, for a good reason, bleomycin, one of its side effects, although it's very effective against treatment of certain malignant germ cell tumors that occur in the testes, one of its side effects after therapy is it causes lung fibrosis. And obviously that would not be good for a cyclist, okay? That would cause them to not be able to oxygenate as well as they would need for the intense cycling they do. So it was actually good that he did not take the bleomycin. He took some other chemotherapy regimen that was quite effective for treating his cancer. And he's been cancer-free, over a decade now, and had won 7 Tour de France's in the meantime and came in 3rd in the last one. So I think that's pretty impressive. And obviously not every patient, you really have to individualize some of these therapy regimens depending on the patient and how extensive the tumor is. But I think he was kind of lucky that way, actually. All right, endocrine therapy. There's other, certain endocrine therapy can also be considered to be used for treatment in various tumors. Hormones bind to receptors in the cytoplasm, can alter the shape of the receptor protein on the surface, and the protein is transported to the nucleus, interacts with the DNA, and this action can initiate new protein synthesis or inhibit protein synthesis, depending upon how the interaction is occurring. It can slow tumor growth or cause regression through inhibition, and it works, again, by interaction with the hormone receptors on the tumor cells. And again, one of the best agents, as I mentioned earlier, example of this is tamoxifen in treatment of patients with breast cancer. Now, tamoxifen is an anti-estrogen hormone, and it's used to help, it binds the estrogen hormone. When a patient is given tamoxifen, it binds the hormone receptors for estrogen on the cell surface, and thereby they're not going to respond to the same mechanism that would normally cause those epithelial cells to proliferate. And a lot of breast cancers are estrogen receptor positive. And so if you give something that would help them grow, obviously by giving them that, it's going to help inhibit that growth. And there's as a matter of fact, estrogens in general are a type of a hormone, and they're not all used for anti-neoplastic treatment, but these are all the different estrogen forms here. These are different androgen forms. Progesterones like Depo-Provera and Megace. Depo-Provera is a type of contraceptive therapy that's given intramuscularly. Megace is actually a type of hormone therapy that's used to help stimulate the appetite in patients with cancer. I mean, one of the side effects of cancer is loss of appetite and weight loss because of that. And Megace actually helps to stimulate the appetite and helps to keep the patients, overall in a better condition, helps to improve their life quality. Steroids, prednisone, dexamethasone, antiestrogens like tamoxifen, as I already mentioned. There's a couple others. Neupogen, I think, is another one, also used for breast cancer. And then hormone synthesis inhibitors such as aminoglutathamide. Now, the last category of chemotherapy agents is immunologic stimulus, and this therapy is predicated on the identification of antigens associated with the tumor on the surface of the tumor cells. And you can use these antibodies against these antigens, and actually you can target certain cells with this type of therapy. There actually is some therapy that's available, a number of therapies available for lymphoma patients that use this type of mechanism and specifically target certain types of B cell markers to inhibit the cell growth of those lymphoma cells. And then there's some other agents. Again, we're not going to spend a whole lot of time here. Cisplatin, hydroxyurea, procarbazine. Some of these are really hard to pronounce, okay? But they can cause chromosome breakage or inhibit DNA synthesis. Now again, what is the effect of these various agents on the cell? Some of it varies with the type of agent, but essentially it's very similar to radiation effect, often with cytomegaly, with varying degrees of nuclear atypia, with maintenance of the normal NC ratio. Here's some examples of cells that are undergoing chemotherapy effects. Look at this cell, it's huge. It's a macrocyte compared to normal. The nucleus is a little bit enlarged. There's a little bit of clearing in the cytoplasm here, but other than that, it looks fairly unremarkable. But this could be a result of a patient receiving systemic chemotherapy, and it can affect any number of cells throughout the body. Because remember, chemotherapy is often given intravenously. Here's another example, a little bit more atypia here, obviously, but chemotherapy can cause a variety of effects, including marked atypia, as seen here. There's still a lot of cytoplasm. There's also a lot of degeneration. I imagine this is probably during the acute stage. Mitomycin C, one of those antibiotic anti-neoplastic agents, is often used for treatment of bladder cancer. It can cause a fair amount of atypia in the urothelial cells that line the bladder, and here's an example of that. It's a very large cell, and the nucleus is also enlarged. Not quite to the degree of what I would expect for a bladder cancer cell, but indeed there's a fair amount of atypia here as well. It could be hard to separate out from bladder cancer. Here's another example. Again, notice the vacuoles in the nuclei as well as cytoplasm. There's still a fair amount of cytoplasm here, and remember, the more cytoplasm, the more likely it's to be benign. Now, Depo-Provera is not a chemotherapy agent, but it is one of the hormones that you should be familiar with some of its effect, because you will see the effect of Depo-Provera occasionally on Pap tests. Depo-Provera is also known as medroxyprogesterone. It's a long-acting derivative of progesterone used as an injectable contraceptive, usually dosed every 3 months. But it can cause an effect on the squamous cells and on the maturation, oftentimes causing a trophic-looking pap smear with a few atypical cells. It's not uncommon for these patients to have an SZCY diagnosis. Some of the newer formulations have estrogen added, which may help. Here's an example. It looks like an atrophic smear. I'd probably call it an atrophic smear, not otherwise specified, because that's what it looks like. And unless I have the patient's history, this could be the pattern seen in a postpartum. Could be, if it's an older patient, could be someone who's perimenopausal or postmenopausal. But normally patients are younger when they're you would think, when they're getting the Depo-Provera. Here's another example where you actually see groups of atypical squamous cells. I mean, just big clusters of them. Again, this would be something called atypical. It would not be uncommon for that. But it is a reason why that sometimes they are called atypical. And of course, this patient would get the HPV testing. It would probably be negative, as long as they don't have that exposure. Here it is on higher power, again, showing you these crowded clusters of cells with nuclear enlargement and some nucleoli, but otherwise fairly regular in appearance. Okay, enough about Depo-Provera. Now I'm going to show you a few examples from the different sites and the different agents to be aware of. We actually already talked about, first of all, bleomycin. Bleomycin is an antimicrobial, anti-neoplastic agent. It arises from the fungus Streptomyces verticalis. It binds to guanine bases in DNA, attacks the bases, and causes single and double-stranded breaks and deletions in the DNA. Now again, the result, the key is to use bleomycin for treatment of certain types of cancers, but the lung, and this drug is given intravenously, the lung is particularly susceptible to the side effects of this agent. The patient may not be receiving bleomycin for tumor involving the lung, but the lung, the normal cells in the lung, have a tendency to respond to this agent in a negative way. The target organ of damage is the lung, and there's often a pneumonitis that first develops, which then progresses to scarring, which results in fibrosis of the lung tissue. The x-rays will show this classic bilateral pulmonary diffuse infiltrate. And the diagnosis is often made by open lung biopsy. And again, these patients when they get this scarring in the lung tissue, it tends to inhibit their oxygenation for the rest of their lives, okay? Can have very debilitating effects. What other things do you see? This is what we see on histology. I'm not going to really focus in on this, although you can in the early stages get proliferation of the pneumocytes, the cells that line the lung alveolar sacs, and we'll talk about that more when we get to the next. This is like a preview to the respiratory module coming up in January, right? Okay. Cytologically, the sputum findings are very nonspecific. There is no way that you can look at a cytology specimen from the lung and say, oh, that must be bleomycin effect. Okay, it's very difficult. But the thing is, there can be atypia. It's important to be able to make sure you don't confuse atypia with something dysplastic or malignant. And usually the benign cells like this are going to show cilia, but then they may also have detached cilia. That's called ciliocytophoria. Again, majority of cells look normal. There may be a few scattered, larger abnormal cells with some atypia. Cilia are preserved, and they're going to show other reactive changes, just like we saw in radiation. And this highlights more of the same on FNA. I'm not going to go, the findings are very nonspecific. Here's some examples of some alveolar pneumocytes with bleomycin changes. It really just looks like a group of atypical glandular cells with reparative effect. And I would want to have to distinguish this from an adenocarcinoma. Now, busulfan is an alkylating agent which binds to the certain sites of the DNA bases, results in misreading of the DNA with breaks. It's used primarily in treatment of chronic myelogenous leukemia, CML. But busulfan is very effective against the leukemia, can cause other effects. Similar to bleomycin, it can target other lung tissues and cause changes, atypia, reactive changes in all of these sites. And so cytology from any of these sites after a patient has received an intravenous injection of bleomycin can show atypia, similar to bleomycin. And in fact, from the female genital tract, the cervix tends to look atrophic. But, that's not uncommon, especially in the chronic state. And again, cytomegalic cells. Now, thiotepa is another alkylating agent that's used in treatment of bladder cancer, especially superficial bladder cancer. It's actually instilled right into the bladder, okay? And the changes are similar to mitomycin C. What we tend to see is a lot of atypia in the urothelial cells with nuclear enlargement, sometimes multinucleation. Again, reactive changes are common. I think it's going to be important, as you'll learn when we get to the bladder unit and these other units, and how to distinguish this atypia from the atypia of potentially something neoplastic. Now, Cytoxan, or cyclophosphamide, another alkylating drug whose metabolite is weakly cytotoxic. Again, this is a drug that's usually given intravenously, but when it breaks down in the body, it has a metabolite that can be cytotoxic to the bladder, okay, to the bladder. And it can result in hemorrhagic cystitis. So in other words, a patient getting Cytoxan for treatment of ovarian cancer or for treatment of lung cancer intravenously can actually have a complication from this, to include hemorrhagic cystitis, which means bladder inflammation with hemorrhage. And because what it tends to do, because remember, these mucosal surfaces are especially vulnerable. And it's particularly in this site, this metabolite tends to concentrate in the urine. So when the urine is stored in the bladder, it becomes, the urothelium lining the bladder gets particularly susceptible to this metabolite. And it can undergo ulceration with necrosis and inflammation, which then during the healing and the reparative process can look atypical. And again, so some atypia is certainly not unheard of here. All right, we're going to talk just briefly about some of these other treatment modalities. I think that's it for the chemotherapy agents. Other than BCG, I am going to talk about BCG and cyclosporin a little bit, which are the immunotherapy type agents. And then we'll talk a little bit about mechanical therapy. And briefly, again, mechanical therapy is defined as where lethal heat or cold, so in other words, electrotherapy or laser therapy, resulting in cell death and an inflammatory response. And there's all sorts of things that you've already been exposed to that can cause this type of injury. IUD is also something that causes mechanical therapy, or effects of mechanical therapy. All right. First off, with the immunotherapy, the two agents I want to talk about are BCG, cyclosporine. And BCG is important to know about. BCG, does anyone know what that stands for? Is it in your handout? Oh, you've been deprived. No, what? Is it in there? No? Bacillus camillus garin. It actually resembles a Mycobacterium tuberculosis. It's very similar, okay? But it stands for Bacillus camillus garin. You don't need to know that. Just, one of those FYIs. It's actually a preparation of attenuated bovine tubercle bacillus. So it's not the one that infects a human, but cows, I guess. And what it does is stimulate. It's actually used for treatment, particularly for superficial bladder cancer, just like what other agent is also used? There's actually two others that are used. We've talked about two others that treat bladder cancer. Thiotepa, and one that begins with an M. Thiotepa, and it's one of the antibiotic ones. Mitomycin. There you go. So remember those, all of the BCG, mitomycin C, and thiotepa, or is it thiotepas? Now I can get them mixed up myself. But those three are the ones that are used for treatment, can be used for treatment of bladder cancer. This BCG is a little bit different than the thiotepa and the mitomycin. Because really what it does is kind of simulate almost like a tuberculous response in a way, but it's not, it's not tuberculosis. but it causes a multinucleated giant cell response, a granulomatous response, similar to what we see in TB. Because remember, that's one of the things that causes granulomatous inflammation. But it has been found to be effective. Again, it's instilled into the bladder. It's not given. All of these agents, thiotepa, mitomycin, and BCG, are all injected into the bladder, basically. Okay, and they've been found to all be quite effective. But the thing is, what you will actually, you may see something like this, where you see someone's going to show you a cell with multinucleated giant cells on cytology, and it's coming from the urine. One of the things you should think about is whether or not the patient had received BCG therapy. Same thing, and you'll get the granulomatous inflammation in other places nearby, including the prostate, can show the granulomas. And again, there's oftentimes some atypical single urothelial cells present. Cyclosporin is one of these, another immunosuppressive agent. It's used primarily in treatment of post-transplant patients to help inhibit the immune response so that they don't reject an organ they were just transplanted with. It's actually a fungal metabolite. That's misspelled there on the slide. There's too many E's in that one metabolite word there. But metabolite relatively specific for T lymphocytes. Remember, T lymphocytes are the ones that function in the autoimmune or in the immune processes specific for transplantation. And so it's important that the effect is inhibition of the antigen-induced signals from the T cells necessary for this response. You don't want this to happen when you have a transplanted substance. So it's important for those patients to suppress the immune response. Cyclosporine indirectly inhibits, results in, unfortunately, one of the, that's the good side of cyclosporine. That's important for these patients. But cyclosporin can also induce tumors. All right, so patients who've been on cyclosporin for a long period of time may be at risk for developing certain neoplasms, including lymphomas and epithelial neoplasms, including cervical cancer. So it's important that the patients get followed very closely. And cyclosporin can also cause damage to renal tubular cells, but I guess in the long run, it's better to have the transplanted organ and then to be followed closely, rather than not be able to live, so there's definitely some benefits to this. And I'm not going to really say this is carbimazole, which is actually a thyroid suppressive agent. It's often used in treatment of certain thyroid disorders. And I'm not going to say a lot more than that. I think that's the only thing you really need to know, is that it has effect on the thyroid and can help treat hyperthyroidism. All right, the last thing we're going to talk about are the mechanical therapies. Now again, mechanical therapy effect can either be due to heat or cold, can result in cell death as well as an inflammatory response. These are the different modalities. We're going to talk briefly about the IUD, review it, because we've actually already talked about it before. Electrocautery, the cytology, the findings mirror a sequence of events encompassing an acute reaction to the injury, early healing, and repair. And generally, it's not recommended that a smear be performed anytime within until after 6 weeks after a patient has received this kind of therapy, because of the effect that can be present from the cautery. In the acute phase, abnormal cells are mostly parabasal and intermediate. Chromatin is enlarged and coarsely granular. NC ratio remains close to normal. The endocervical cells are often in aggregate, slightly enlarged with coarse chromatin. And the chromatin can get a beaded appearance. It's undergoing degeneration. And then, of course, there's repair. And the cytologic features are similar to those of typical repair due to other causes of mucosal injury. Now, with cryotherapy or freezing, what happens is that the cells form, there's ice crystals that are formed, and these ice crystals can cause necrosis and inflammation. And then you can get reparative changes, and cellular and nuclear enlargement is not often as present. It's usually the cells undergo marked degeneration. And there's actually one study, and I think this is actually taken right from Koss's textbook, but they describe two cell types, the first type and the second type. The first type being in these large sheets, small aggregates, sometimes single cells, whereas the second type occurs more syncytial with small uniform nuclei. I don't know, they sound similar to me, but I think that I think it's just important for your purposes to understand that cryotherapy can cause a lot of damage, and you tend to get these aggregates of cells with karyorhexis and vacuolization. Now, laser therapy is intense focused heat which inactivates cellular components. Greatest thermal damage occurs in cells with low water content, and the cellular replication process becomes interrupted. On cytology, it has similar sequent events as does cryotherapy. Dehydration causes the cells to look distorted. Reparative changes are present usually by the 7th to 10th day, and normal cells may be seen again by day 21, which is about the relatively normal cell cycle in this area anyways. Now, what about leaps? Now, we see a lot of leap specimens, and we tend to see a lot of electrocautery and heat, or I should say thermal effect from the leap devices that are used. We see that more often on the histology preparations because that's what we get the specimen submitted for, is histologic evaluation. I guess what I want to point out with the LEAP device is that usually right at the edges where the thermal effect is most prominent, where the tissue is being excised, the cells tend to get kind of pulled out. In other words, almost like it's pulled taffy in a way. You get the cytoplasm and the nuclei looking like they're being pulled. And sometimes we'll see that on cytology if there's a pap smear taken around that time. And really what it represents is just the cells being damaged by the heat and being pulled away. It really has this they described it as a taffy-like appearance. I'm not sure I have a picture here. No, I don't. Well, sorry. But just if you think taffy and leap, right. All right. Despite that effect, the leap is it's much better than the cold knife and the laser cone procedures. It's faster and easier to perform. It's done as an outpatient, better tolerated, uses low voltage, high frequency wire loops to remove the cervical lesions, and induces injuries similar to that of laser treatment. Again, here's an example. You saw some pictures of the different size loops last week when Dr. Leith showed some pictures. And again, this is just one example where it's primarily taking out the entire transformation zone right here. And where we tend to see the changes are in the this taffy pulled appearance is being described here. First of all, the initial acute inflammatory response may simulate a tumor diaphysis. There's often repair, and then the epithelial cells get elongated or spindled with this degenerated eosinophilic cytoplasm and elongated cigar-shaped nuclei that give it this taffy-pulled or hockey stick kind of shape to them. And again, we see this primarily on histology, but if there were a pap smear done at this time, it would not be uncommon to see it on the cyto as well. All right, the last thing we want to just review is the IUD, because the IUD is a device. It's a mechanical device. It can cause certain effects too on cytology. What is the organism that we see with IUD? Actinomyces. Or at least when we see actinomyces on the pap test, you can suspect that the patient has an IUD. But indeed, the IUD can also cause atypia amongst the squamous cells, amongst the glandular cells of endocervical origin, and of endometrial origin. Okay, the glandular cells often show can be hypervacuolated. Sometimes we call them bubblegum-looking cells. They get so hypervacuolated. The nuclei can be enlarged and pleomorphic. There can be nucleoli. There can be atypia amongst the glandular cells to the point that we'd want to call it an Agus case, right? Or AGC. But again, history is very important here. sometimes IUD causes these indeterminate cells, these single cells that we don't know where they're coming from. Are they squamous? Are they glandular origin? But they tend to be single cells with very high NC ratio that resemble CIS. In this setting, they're actually referred to as the DING cell. Okay, that's an old term. Again, the cells are single cells. There's not many of them with very high NC ratio and hyperchromatic nuclei. Now, they may have nucleoli, which helps to distinguish them in some cases from CIS, which doesn't usually show nucleoli. Now, the atypia from the IUD can revert. In other words, the atypical changes on the epithelial cells that are being affected by the IUD effect can revert to normal within a period of months after removal of the IUD. Actinomyces can be present, as noted, and growth is promoted if the IUD is present for more than 2 years. And in patients who are symptomatic from the actinomyces, usually are treated by having the IUD removed. Here's an example of those quote-unquote DING cells that resemble CIS. You get a few isolated cells like this with very high NC ratio that resemble CIS, but they're not. It's actually due to the atypia from having an IUD in place. And again, they're called indeterminate cells because we can't tell if those are squamous or glandular, really, in some cases, in origin, but they really do look like metaplastic type squamous cells that are very immature. And I think that's it. Any questions? All right, well, that was a whirlwind of therapy-related effects, but as you can see, there's quite a bit of overlap. There are certain ones to be familiar with. There are certain time periods to be familiar with, and I think you'll be fine. All right. Congratulations, you made it to your last lecture of this block. Yay. Of course, now you got some tests ahead of you, right? Little quiz next week. And then within a couple weeks, we should be seeing you, at least some of you over at BAMC. Do you know where you're rotating to first? Some of you? No, not yet? Very soon. I'll see you around at BAMC, that's for sure, within some of you within a couple weeks. So, okay, thank you all.